Hello, everyone. Welcome to Genome British Columbia's Data Literacy webinar series. My name is Zsuzsanna Hollander, and I'm the Director of Data Science at Genome BC. While today we meet on a virtual platform, I would like to take a moment to recognize and acknowledge that I live, work, and raise my family in Vancouver, British Columbia, which is on the unceded traditional territories of the Coast Salish peoples, including the Musqueam, Squamish, and Tsleil-Waututh nations. We started this webinar series in 2022 with the aim to bring national and international experts together to help deepen our understanding of different data-related initiatives, standards, and resources. Today, we're starting a 2-episode mini-series on health data access platforms in BC. Today's presentation is focused on the Integrated Health Informatics Data Lab, a mouthful but short, IHID, by Providence Healthcare Ventures. This is a transformative resource designed to empower researchers, industry professionals, and government stakeholders in the health data ecosystem. It is my pleasure to introduce our speakers, and because we have 3 speakers today, I'll be very quick with the introductions. Alex Nguyen is a business development manager at PHC Ventures. He's an accomplished healthcare innovation specialist with over 5 years experience in life sciences sector. Dr. Zoltán Bozoki is the director of software engineering at PHC and a senior scientist with a demonstrated history of working in pharma. Next, we'll have Dr. Andrew Kessler, who is an emergency physician and public health expert with comprehensive training across healthcare administration, public health, and tropical medicine. And last but not least, Dr. Scott Tebbett is here to give opening remark. He is a dear former colleague of mine. He holds many hats, including being the Director of Research at Providence Research, Principal Investigator and Director of Education at the Center for Heart-Lung Innovation, and CEO of the Proof Center of Excellence. And with this, I'll hand it over to Scott to give the opening remarks.
Well, hi everyone. I want to wish you all a warm welcome to today's presentation on data access with the Integrated Health Informatics Data Lab platform, or as Zsuzsa said, IHID for short. So my name's Scott Tebbett. I'm the Director of Research at the Providence Research Institute. And today we're going to focus the next 45 minutes on the IHID platform itself, how it can be leveraged, and how PHC, or Providence Healthcare Ventures, can support you. We'll also feature Dr. Kessler as a researcher spotlight. So just so you know, as a strategic partner with Ventures, we've made IHID free to access for all Providence Research affiliated researchers. I also want to put out a big thank you to Zsuzsa and her team and to Genome BC for hosting this webinar and recognizing how instrumental Genome BC has been in supporting the development of the IHID platform. This partnership with Genome BC is the reason why IHID actually exists. Okay, so innovation has been happening organically and broadly at Providence Healthcare for well over a century. To build on this, we've created the Innovarium, which is an innovation engine to promote a unified mindset and streamline low-barrier innovation and connect efforts across the entire organization and beyond. The innovation is not a physical space or a department, but it is embedded throughout Providence Healthcare. It links people, their ideas, and initiatives to drive positive change. And by connecting all parts of the innovation cycle, from ideation to implementation and even commercialization, we're accelerating impact. And IHID is a great example of this in action. Next slide, please. So this is my final slide, and it's really just sort of, as I've mentioned previously, without the partnership of Genome BC, IHID would not be where it is today. This partnership has provided researchers with the opportunity to analyze and compare genomic and other omic type data, for example, from blood samples, taken for a research study and linking these data sets with Providence Healthcare's clinical and even imaging data from the same patient populations. So these 4 projects that are outlined on this slide were originally funded by Genome BC, and they have enabled researchers to put IHID through its initial paces. And so, we've been lucky enough, my own group at Providence has been lucky enough to get one of these studies in heart transplant biomarkers. So we were able to link molecular data from blood from heart transplant patients, and we could develop biomarker panels that could predict or diagnose outcomes, other heart transplant outcomes due to, say, immunosuppression. These included cytomegalovirus reactivation and kidney injury. And so to share more about the actual IHID platform itself, I'd like to introduce Alex Nguyen, who's the Business Development Manager from Providence Healthcare Ventures. Over to you, Alex.
Thanks, Scott, for that introduction and as well as that brief history with Genome BC. I'll just add on to that as well. It's that partnership was truly instrumental in the development process of the IHID platform, which was developed by Providence Healthcare and PHC Ventures. So really providing the first group of researchers as a use case to develop the IHID platform. So just really want to recognize that really bridging the gap between innovation and clinical care within Providence. So that's the data access piece, but we also, wanted to expand in different ways within the ventures model. How do we bridge the gap between clinical care and as well as innovation? And just wanted to quickly touch upon these before digging deep into the IHID platform. But the ventures model also comprises of providing clinical advisory service with industry partners. We also make strategic investments within VC-based companies. And most recently, which was listed as one of the projects with Genome BC, was Dr. Zach Laxman, who's one of the founders of MyTrials.ai. And that's actually an example of one of the strategic investments Ventures has made within Providence Healthcare as well. We also provide commercialization support for our innovators as well. So, healthcare data is increasingly becoming more and more important, and it's no longer really a byproduct of delivering care, but a tool to really improve care. So whether that's improving or growing emphasis on data-driven health innovations. So some examples of that would be using data to personalize care, to really understand what's going on within the practice of care, evaluating it, how can we make it better, enhancing the system efficiency, and as well as making evidence-based decisions when improving care. It's also especially true with medical technologies, especially ones that really have an emphasis on AI and machine learning. So these type of technologies really require a lot of clinical data to really develop it, test it, validate it, to ensure that it's clinically meaningful and as well as it's ethically sound. With BC's provincial innovation strategy being rolled out, to be seen as the innovation leader within BC, there's an important need for data to really allow researchers and as well as innovators to really develop, evaluate, and scale new technologies, whether that's for new treatments, new models of care. Providing access to a robust, secure, and usable health data is really critical in enabling researchers and innovators within BC. Healthcare data has its challenges, unfortunately, when we're trying to access data. So when we were working with our researchers, a lot of the things that they told us was accessing or just the process of procuring data is very cumbersome. Cumbersome in the terms of it's scattered everywhere, it's in different systems, it's in different formats. So it's really hard to link it and analyze it together. It's also not prepared in a way that's really meaningful for them. So they can't just get the data and then use it right away. So they have to de-identify it, they have to process it, they have to clean it. That way it's researcher friendly and they can use it immediately. So, these things kind of add up to the processes it takes, the resources it takes to access data. There's also a consideration for governance process as well. So when they're accessing data, using data, what are the considerations that researchers have to make to ensure that they are protecting patient privacy, and as well as the data doesn't get released in a unethical way. So there's a consideration for that, and sometimes it's just not very easy to navigate that process. And all of these factors combined really add to the resources required to procure data, use data, and as well as results in a high cost of acquiring data. So how does IHID really help researchers overcome this and really enable them? So IHID is essentially a trusted research environment, which is a comprehensive solution that brings together data, collects it, links it together, de-identifies it, and shares it within a cloud-based environment. And data sources could include Cerner, medical imaging, lab data, medication data. So really broad sources there. It really helps research. IHID has really helped researchers answer a lot of specific questions. And some examples of this could be from a retrospective analysis, really to understand what's happening within their practice of care and improve it. For some examples, it could be developing prediction models so they can intervene with patients a lot earlier. Some other cases could be training AI algorithms. And in some cases, it's a good way to also optimize clinical trials and make it more efficient as well. IHID is also a privacy and security approved product. So, the considerations when it comes to governance processes, they're covered through that umbrella that IHID has those approvals. With every project, we also require ethics approval. So that's another step into ensuring that patient data is being used correctly. And we've actually worked really closely with the ethics board to really streamline that process, ensuring that the time from an ethics submission to the approval is really streamlined and it doesn't take very long. We also wanted to function more than just data stewards as well. So we provide researchers with a customized workspace that provides all the compute capabilities, the storage, and specialized analytic tools to really enable them within the platform itself. So, by streamlining all these different processes, it allows researchers to really focus on the research component rather than the procurement process of data. So really enabling them to accelerate the discovery process from, what could have took maybe a year, 2 months to now weeks. So really streamlines that process for the researchers. So to talk a bit more about the IHID platform and the more technicals about it, I'll pass it on to my colleague, Zoltan Bozecki, Director of Software Engineering at Providence Healthcare, who will talk a little bit more on the technicals within the IHID platform.
Thank you, Alex, and hi, everyone. You might be interested in that what is IHID or how IHID works, and I will just deep dive into that. So first of all, what is IHID? IHID is a secure data sharing platform where data exists and people can have access to that data, but they cannot take away data. So it's a secure data sharing platform where de-identified or anonymized patient data is provided, or at least access provided, but it stores and keeps the data intact. IHID collects, analyzes, and de-identifies data within its boundaries, and it also links different data sources together. So if you have clinical data or imaging data, we link them together so it appears in the platform as one unit. We protect all the patient privacy. And all projects require a lead principal investigator and a full ethics approval before the data can be accessed. So one crucial thing is that it's a mix of clinical information, a mix of demographic information, and a mix of potentially externally collected information, which enters this system in a secure way. We have a special airlock system to do so, where the data can be accumulated inside and linked together and worked together. Alex, if you can move to the next slide, please. Currently, we have about 1.5 million patient record clinical information, demographic information available, and a little bit more than 3 million medical imaging exams, including both medical imaging reports as well as the medical imaging images available, together with some pathology data. And on the screen, you can see that, at least for the medical imaging, these images belong to which body part and which examinations. These are all available for the researchers. You might wonder what kind of tools are available within this platform. So IHID provides a Windows-based environment and tools for analyzing images and omics data. We provide programming environments and different scripts capabilities, as well as on request, we can provide GPUs or other high performance needs compute to process all this data. Ventures at the same time also provides consulting, so helps you get through the ethics approval. We can provide data scientist resources and in general data analysts and other resources. And because of the structure how IHID is built, loading and linking the data is also a service that we provide, and it's a low-cost data access environment. Important thing is that we charge industry partners for this data access, but if you are associated with Providence Research, then we can provide this service with no cost. Alex, if you can go to the yeah, thank you. So how does user journey looks like? So first of all, it starts with an intake process. We need to understand what is the research project, what are the data needs, and how many people needs access to the platform. Then we do a data discovery and scope development phase, where we look through all of our data resources and collects a specific data sets for this research project. Next, we go through ethics and data governance review and assessment. We provision the actual workspaces, so each user of this environment will have access to a dedicated Windows environment where the data is provided. Data sharing between users is available, but everyone works in their own environment. And then if all of these are successful and finished, then the project can start. But along the project, all the way till the end, Ventures provides project support, regular check-ins. Often there is an issue of having access to more data is necessary or some adjustment, and we all provide support for that. And if you have been exposed to IHID, you might wonder that what's new for the past 2 years since the system is operational. We did some improvement. Some of them are in the background, some of them are in the front. So IHID provides a near real-time data access to clinical information. We implemented automated tools to faster setup. So once the project is approved, getting access to the actual environment and the data is faster and a quicker onboarding. And coming soon, we will provide not just clinical information in the format what Providence has, but in other data standards. For instance, OMAP is one of the commonly used data standards, what we are working towards to provide all data in an OMAP format. I think one of the crucial questions regarding data sharing is always data privacy and how patient information is handled and making sure that everything is safe and secure. So we respect, first of all, patient privacy. So if is not needed, then data is provided in a de-identified and anonymized form. Sometimes we include study ID to help even the researchers to use their ID system to look up a patient. There is this ethical approval and Providence research approval, making sure that the use of data is aligned with what the research want to achieve. Currently, mainly we have access to PHC data, but we work with other partners, and you can see some of the partners' name on the screen, where we try to partner up and collect information and data from there. So it's basically one unified interface and one unified process. You don't need to go to other organization and learn their system, how data is presented. And all projects are reviewed by the indigenous data governance team. So we are making sure that the data is provided is really non-identifiable or it's compliant with all the necessary standards. Next, I want to introduce you to Dr. Andrew Kessler, who will talk about his experience on the IHID platform and that very interesting research project what they did recently.
Thank you so much, Sultan, and thank you not only for the introduction, but for all the help that you and your team have provided in this project. So this project I'm going to talk about in the next few minutes is a EMR alert, or electronic medical record alert, to improve diagnosis and treatment of opiate use disorder in the emergency department. Next slide. I don't have any commercial interests to disclose. I have a number of affiliations for my quality improvement and research work. Next slide. So I've been working in, I'm an emergency physician, and I've been working in the substance use care space in the emergency department for over a decade. And one of the problems or an issue we see is that a lot of people with opiate use disorder use the emergency department as one of their primary points of care. They may not have other points of care. We also know that this is a group with a very high short-term mortality. Everybody is familiar with the opioid crisis in BC. And so we want to use the emergency department encounter as an opportunity to recognize this condition and to be able to offer some interventions. The problem, as I'll get into another problem I'll get into in a second, is that when people present to the emergency department, they may not disclose their substance use, or they may have a chief complaint that is not clearly related to substance use. So the hope here is that electronic medical records can help us identify people who may have a background of substance use and to offer them interventions that may be life-saving. And this brings us to our research questions: is can we use an electronic medical record alert for ED patients meeting sort of some kind of algorithmic criteria for opioid use disorder or a similar proxy? And can we increase identification of this condition and the frequency with which we give interventions compared to similar patients in a period prior to activation? Next slide. So this is, again, just to sort of show you from some work we did a long time ago about the issue of people not necessarily presenting in an obvious way. And this was in-person screening we conducted in an emergency department in 2015. And we actually had research assistants going around talking to people and doing very active screening for opioid use. And we found out that over half of patients who have a background of opioid use are presenting to the emergency department with reasons that are, may, at least on the surface, have nothing to do with substance use. Next slide. So this is part of the impetus to create an opioid use alert that would use chart data, would do a dive into the electronic medical record to find out if there was potentially a background of substance use, and then to alert the provider. So this is what the alert looks like. On the left-hand side, you have a pop-up when the emergency department provider first opens the chart. And again, it's not saying this person definitely has opioid use disorder. It's encouraging you to screen a little bit more. And if the patient turns out to have ongoing opioid use that is sort of non-prescribed and not within a medical context, that you can start offering some interventions. If you want more information on the alert, you can click that sort of bottom left button, Orders and Data, and get some background on why the alert activated for this particular patient. Next slide. How does the alert actually work? So it looks back at 2 years of electronic medical record data. This is looking across the system, so the whole Cerner universe in Vancouver Coastal, and it's looking at medications received, previous emergency department diagnoses, as well as inpatient discharge diagnoses. Next slide. So once we put the alert into place, you can see that we actually, across the system, have quite a few visits. This is just looking at 3 hospitals, St. Paul's, Lionsgate, and Vancouver General, and not even looking at admitted patients, but just looking at discharged patients. And you can see that at St. Paul's, for example, there are around 1,500 or more visits per month where the alert activates. And, again, this reflects our demographics at St. Paul's. And we can see there is certainly a good number, but fewer at Lionsgate and at VGH. Next slide. And again, to sort of validate this alert and is it working, we're just seeing if it's comparable to previous data we looked at in our patient population. And here again, we can see that the people being identified with a history of opiate use, again, the majority have a non-substance use related complaint at presentation. So over 70% in this case do not have a presentation that is obviously linked to substance use. Next slide. Here we can see that of all the people for whom the alert activated, about 20% across the region. This is at the 3 participating hospitals here, St. Paul's, Vancouver General, and Lionsgate, received an intervention. Next slide. And this gives you a slightly better intervention slightly better idea of the interventions. Here's just drilling down at 1 month of St. Paul's data in January 2024. And we saw that about the 17% received interventions. You can see the sort of 2 larger slices of pie on the right of the screen are addiction medicine consults and addiction nurse consults, and those account for over 50%. You've got another good chunk, 25%, that is related to receiving take-home naloxone kits, and then another 25% related to receiving opioid agonist therapy in the emergency department. Next slide. So this is how we undertook our study, and we started this process before I was aware of the IHID platform, and I'll come back to that in a second, why that's important. But we set up the study to be a before and after, and so we defined a before cohort using people who had presented to the participating emergency departments in the year prior to alert go live, and then seeing if they had previous opioid-related diagnosis in the system across the region. And then a bit easier again to define the post-alert go live cohort was just the people or the encounters in which the alert had activated. Next slide. Our primary outcome is to see if people received an intervention related to substance use or addictions while they were in the emergency department. A simple yes, no. And secondary outcomes are looking at, was their opiate use or their substance use recognized, looking at specific interventions that were received, and also looking at 30-day emergency department revisits. Next slide. So our planned analysis are some descriptive statistics of the pre and post groups, and then looking at the frequency of primary and secondary outcomes in the pre and post groups. Next slide. So how does IHID come in? So it's come into cohort identification. This is the first step in terms of defining the population. In terms of defining our pre-alert population, since we started before I knew about IHID, or our team was working with IHID, we used a regional ED database to define this pre-alert cohort, and then we were able to use IHID to identify the post-alert cohort. And then the data that IHID has been able to pull for us based on these qualifying visits in Cerner are the interventions delivered, particular data on ED visit characteristics, and some patient demographics. Next slide. So of course, in retrospect, I wish we had been working with IHID sooner. It's been laborious and time consuming to identify this pre-alert cohort, and certainly this is the type of project in the future that we would use. We would ask IHID for help in defining the relevant cohorts. Next slide. So it's been a real pleasure to work with IHID, and there are a number of advantages. Certainly the user interface, the Amazon Workspaces is user-friendly. It's easy to get onto. There is multi-factor authentication, but it is not overly onerous and easy to use. The data team has been very responsive to adding fields of data, running some test data for us to make sure that all fields we need are there. And also, and there are always some minor glitches with the output. Is it easy to interpret? Are there any inconsistencies? And we have found the team very responsive in terms of being able to modify the output formats just so that it's for maximum usability. Next slide. All right, so our next steps is we're just continuing with the data pulls by IHID, looking at the 30 ED revisits. We have still some data cleaning to do and some analysis, and certainly the goal is to publish and to share our experience with EMR alerts, and hopefully this is something that will be generalizable to other settings, and other settings may find useful in taking care of their patient populations. I think it's back over to you, Alex.
Yeah, thank you for that overview of your project, Andrew. So I think it was really interesting to see, you can kind of see the stark difference between what could have happened having access to IHID before starting the project, and as well as what's happened after. So, you know, really have seen that impact when it comes to time to access to data, and as well as starting the actual research itself. So thank you again, Andrew, for that overview. I have a couple more slides before we conclude, but just want to touch on a couple of things. I think, you know, one of the things is, you know, data partnerships. With the IHID model, we're always open to working with other partners, data providers, data registries to really link the data that we have with other resources and really expand that into more longitudinal data, making it more effective within research. So by doing this, you know, we provide IHID as a shared resource for our data partners. They use that as a mechanism to share their data with other providers or other researchers. And, we have all the established agreements, whether it's, data provider agreements, revenue sharing agreements. We've established all of this to really make it a streamlined process to really work with other health authorities, data registries, and other researchers who may have data. So, how do you get involved? It's fairly straightforward. It's, we try to make it as streamlined as possible. So, we have a QR code here, which basically links you to our intake form on our website. The intake form is very straightforward. You fill in, what are your data requirements, and then that kind of starts the discovery process. But if you're not really sure if, this IHID platform is something that would be effective in your project or a use case within your project, you can definitely reach out to one of us. One of us will, have that conversation with you to see, is IHID a right fit within your research project, and we can kind of go from there. So fairly quick on the turnarounds on that process. And yeah, so before I conclude, I just want to thank you again for all the presenters who's joined in today, and especially Genome BC on their involvement when it comes to the partnership that we've had. We've had a long-standing relationship there, and allowing us to again speak on behalf of Ventures and the IHID platform within this data series. So thank you.
Thank you so much, Alex, Zoltan, Dr. Kessler, and Dr. Tevet as well. This has been great. Also seeing how much improvements happened since the running of those 4 DIA projects that we funded. It's been really great. And I'm especially excited to hear that the PHC associated researchers will have free access to the platform. That is, I think, really, really amazing. We do have a few questions that have been posed online. So I'll read them off and then I'll let one of you take it. Are there any plans to expand the free access to researchers associated with other health authorities or public institutions?
Sure, yeah, I can take that one on. As of right now, there isn't plans to do so, but I think what you can do is become affiliated with Providence Research. So there are certain steps you can take to be affiliated with Providence Research. I don't believe you have to be affiliated with Providence Healthcare to be a Providence researcher. Maybe Scott, you have any more insights on what that process may look like in terms of, becoming a listed researcher or affiliated researcher with Providence Research.
Not specifically, but I think I would recommend people get in touch with us, right? That's the first step, and reach out. Please reach out. And I think this is we're sort of an all-encompassing healthcare system supposedly, so we need to sort of act like it. So please reach out. Andrew has his hand up too.
Yeah, no, just to add to that, another mechanism, and we've used this for various projects, is if it's a project that involves Vancouver's VCH-wide data, and of course PHC is part of that umbrella, then one option is just to partner with a PHC researcher, since some of that data is going to involve PHC data as well, and therefore have access to the entire system data. So with the right data permissions, operational approvals from VCH through my IHID access, I've been able to access data from across the VCH system, whatever's been in Cerner. So that is another sort of avenue I wanted to mention.
Just one last thing I want to add too. There are research centers also affiliated with Providence Research. So, Center for Heart and Lung Innovation is affiliated with Providence Research. Center of Advancing Health Outcomes is another one. There's a few others, BCCSU. These are all affiliated with Providence Research. And because of that affiliation, you are part of that Providence Research portfolio, for lack of a better term.
So maybe a follow-up question, and that could be a quick answer. I love that the access is free. Is it free forever? Maybe not forever, but next 5 to 10 years if there is a longer-term project.
That is a great question. As of right now, there isn't any plans to not continue with providing free access. And this is part of the partnership that we have with, Providence Research. So I think the important thing is if we continue to see that researchers are benefiting, continuing to use, and we're seeing a lot of requests through this specific method with Providence Research, then, we'll continue to support that in that case.
Yeah, that's a great thing, because I know for the DIA, obviously there was a limited access as part of the projects. They were 1 year for the funding. But I know from previous work that we've done with Scott, some of our projects spent 10 years. And so being able to access data throughout those 10 years is important. Another question related to years is how many years of data are available in IHID? That one of our viewers have asked.
Yeah, so I mean, I can quickly touch upon this, and then Zoltan, I'll pass it to you to fill it in. But as of right now, it goes pretty far back. The sweet spot for us is around 6 years, is because Cerner was implemented in 2019. So between 2019 and now, it's the best spot because Cerner is there. There's more data variables available. We could technically go further back than that, but because it was a different EMR since then, there probably will not be as many variables available. But Zoltan, feel free to add anything that I might have missed.
No, you're absolutely right, Alex. So the clinical information goes back to 6 years by default because of the Cerner transition. Maybe one important thing is that the imaging information goes back to way beyond 6 years. So the reason why we have access to this 3 million plus imaging information and just 1.5 to the clinical information is because of that. So because the imaging data goes back, I believe, more than 20 years if needed.
Thank you, Alex and Zoltan. Another related question, we've been talking about Cerner. The question is, are other electronic health records represented?
As of right now, since it is Providence-based data, it's mainly just Cerner, since that's the EMR that we use. So, Zoltan, anything out there?
Yeah, I just want to emphasize that if there are externally collected data, which is not necessarily EMR, but can include EMR, so these research projects have the opportunity to bring in any external data sources, and we can link them up with PHC data, or it can just leave without linking up to any data provided by PHC. So there is a possibility, if the team has access or collected surveys or have some external sources, to bring into the same platform and analyze in the same platform.
The next question relates to ethics. How long the ethics reviews take? And I'm assuming your answer maybe depends, but I think it obviously relates to how long one has to wait before they can access the data.
Yes. Yeah, you're right on the point on that. It always depends, right? Because it's handled by UBC, Providence Research Ethics Board, so it's kind of externally controlled. But we work very closely with them, and when we were developing the platform, that was a consideration as well. So how do we make that streamlined as possible? So we have, for example, an overview documentation that goes over the privacy, security, and the use of data and consent within a single document that could be attached with the application. And as I mentioned, we've worked really closely with the ethics team to really streamline that process. How do we make it quicker? But again, it always depends, right? It depends on how many requests they have, what's their current capacity. So it really varies. And our goal is to always try to get it as a minimal risk, but there are times where it goes to full board as well. So that's also a dependency as well.
And I'm wondering, I don't know if when research studies are about to start, I wonder if the ethics committee could suggest to researchers to include the use of IHID, especially for those that are originating from PHC and would be requiring access to clinical data, so that it's part of the initial ethics application, and they don't have to wait any additional time later on once the study is up and running to access clinical data. Maybe Scott wants to answer that.
I can add to that. So, you know, Providence Research is and Providence Healthcare are sort of trying to implement a more generic, sort of widespread biobanking initiative. So where we can basically, you know, if people are thinking of putting together a new study, they have an option to sort of tick a kind of a universal biobanking consent, right? So samples and data would go into that sort of process, and that would make their data, imaging files, molecular analyses, all these types of things much more readily readable through our platforms such as IHID and things like that. So definitely encourage any researchers or clinician scientists to sort of look at that when they present their ethics applications, because it is a subcomponent of the sort of the CREB boards. So, you know, so we're trying to sort of make this a little bit more universal if we can. Yeah.
Thank you, Scott. That's really amazing to hear that that's already in place. I think that's going to be helping a lot for secondary use of data. So related to that, before I get to one of the other questions that the audience has posed, I was wondering, I don't know if this is a question for Alex or Scott, there is quite a few already existing biobanks within even the Center for Heart and Lung Innovation. Are you linking those to IHID, or is there a patient consent that allows you to do that?
Scott, you want to get a step at this one?
Well, I can, you know, obviously for our long-standing heart transplant, you know, Juge has been instrumental in working with for years. You know, we have a generic biobanking consent as part of that, right? So when patients who are undergoing heart transplantation, when they're invited to become part of the research study, there is a consent form for generic biobanking. So that allows us in those instances to sort of bank specific samples, take that data out of those samples, molecular analysis, whatever, and then that sort of short circuits this whole process. And that's what we use for the IHID project that we're involved in a year or two ago. So that was one example of a biobank that's there. So there are other biobanks. So there's the Bruce McManus cardiovascular biobank, the Jim Hogg lung thoracic biobank. There's the renal biobank. There's the COVID-19 biobanks and things like this. So there are a lot of biobanks. So theoretically, some of those should be able to be linked in, but I think it will be very project specific. So I think, you know, the process would be, you know, approach Ventures and Providence Research, discuss potential projects, and then we can link in with the biobanking consents as needed. And Alex, if you have any other insights, that would be good.
No, I think you've got it for the most part there. And I think depending on the nature of the project too, in regards to consent too, when we work with ethics, there sometimes are requests for waiver consent, and that's a specific consideration, right? If we're dealing with samples that are really, really old and like the patient may have already died, or, you know, as long as the patient's the data de-identified, there are certain considerations that may allow the ethics to approve waiver of consent. So that's also a consideration to that.
Let's switch a little bit to medical images. The question is, are the images view only, or is there access to the full image files?
It is access to the full image file. So if there is a study, usually it's not just one image file, but many for a given exam. But it's access to both the de-identified metadata information about the image files, as well as the pixel content.
And we can go back to sort of the time required to access IHID. So assuming there is a researcher who already has the proper ethics application and, you know, they had the approval, how long does it take from there once they submit a form to access data?
Yeah, this again, it's always dependent. We try to work as quickly as possible with the ventures team. That's the great part about having ventures as a whole, right? We have these dedicated resources to support the researchers. We have data analytics to support the researchers. So really, really quick in that process from time to request to access. But yeah, I mean, it really depends, right? In my experience, it could range from, a couple of weeks, assuming, let's say they already have ethics approval, it could be a couple of weeks to a couple of months. So it really depends on that. And that's the other consideration too. It's like ethics. We need to have approval on that first before we provide access. And usually that's kind of the part that may delay the process access. But again, these can be done all in parallel. So, we try to streamline that process.
Zoltan?
Just to add on that, data discovery and the complexity of the data need is usually also a key factor in terms of how long does it take. But Alex is right. I think the shortest maybe on a couple of weeks time, and the longest goes up to like 2 months-ish, plus minus a little bit.
So I'm assuming, based on what you two were saying, that some of the time sort of spent is on trying to figure out what the user wants. Do you have it? Do you have any information on your website relates to one of the questions as well at what data sets are available to request access to so that, this process could be sped up?
Yeah. So a couple of things. We do have like a data dictionary that we've developed that's meant for kind of internal use. We don't publicly share it, but if a researcher is not really sure what's available, then we can share that more confidently. And one of the other things that we're working towards as well is a platform where researchers themselves can actually do like a high-level query and kind of see what cohorts are available. So that's in the process of being developed as well to really streamline that process of seeing like, okay, just as a quick glimpse, like what's there. So that's also in the process as well. But my recommendation is always just connecting with us. That way you can talk to the actual data analytics team, you can talk to myself, and then we can really see how we can fully understand your requests and support you.
Related to what's available, are the DICOM files for the scans in the database accessible?
Yes, absolutely.
Wonderful. The cost associated to the service, I'm assuming this is one of those depends, but I don't know if you have a range that you could provide for sort of the simplest data access to what, what generally is the cost of accessing data.
Yeah, it's all dependent on the scope of the request, right? So how much data is being requested, the complexity of the curation that's being asked, as well as what are the requirements for the IHID platform as well, right? So if they're doing some AI development within the platform, most likely that may require GPUs, maybe more storage, and these are like things that add to the cost of the project itself. So it's always project by project, and it's difficult to give a definitive answer on cost ranges as it really varies.
Okay. So some more questions around what's available through the platform or what are you planning on integrating? So for example, primary care data, do you have any plans on integrating that, or is that a possibility?
Yes, that's a very challenging one. Primary care is a very challenging one because it's, they're all using different EMR systems. They're all kind of operating on their own, but I think the thing is we're open to working with them, and with the IHID model, we're always able to open up the platform where data could be brought in. We can also have a mechanism to partner with other, data registries, data providers, to really be part of the IHID environment as well. So as of right now, there isn't plans to, to really facilitate that because that's a challenging one on its own. Considering the vast amounts of different systems that they're using.
I mean, I totally get the question. It would make life a lot easier when one does research, but I know that it is quite challenging. Are there plans to integrate VPP data into IHID, or alternatively to pull data together into Health Data Platform BC?
I'm not aware of VPPP. What is that?
Zoltan?
So VPP is the joint name for Providence, VCH, and PHSA. I think we have plans. Whether politically it's possible, that's another question. So yes, we want to increase the data offerings and have a more tight collaboration with the other partners. Therefore, we work with these other health authorities. At the moment, we only provide primary PHC data through the platform.
Okay. And so one more sort of lower down the line, I'm just trying to cluster questions around the data availability. What is the most recent year of data currently available for requests? So I'm assuming this is up to date, or do you have, I don't know how real time it is.
Yeah, so we say it is technically real time, but we usually don't suggest like asking for data, up until like, let's say today, right? If you're, requesting the data today, just for, specific reasons such as like, you kind of probably want that data to settle for like a month because it may change, things like that. So technically it is close to real time, but our recommendation is to kind of leave a buffer between today and maybe like a couple of months just to really let that data settle.
Just to add on the top of this is that one of the improvements what we did since the IHID project started is to improve the, I don't know where my video went, but improve the timing of the data delivery. So when we started the IHID journey, data was delivered basically on a quarterly basis. So let's say 3 months old data was the youngest in the platform. Right now, technically, we can deliver even same-day data. We don't do that just because of the reasons what Alec mentioned, is that the data needs to be settled because for the past, let's say, couple of days, the data can change. But in terms of the platform capability, near real time or within a couple of days, data can be delivered.
All right, so we have a few more questions. I'll try to bundle a couple of them. You mentioned the availability of image. Within the DIA program, we had genomics data. And the question is, does it support analysis of multimodal data and to use in the context of personalized medicine? Sort of the two questions together. I'm assuming the answer is yes, given the experience in DIA, right?
So the platform supports multimodality data. The question is the linkage and where the data is coming from. So if it's some weird data collection, then we need obviously some sort of patient identifier to link the data together. But in terms of capabilities, yes, the platform can support. Maybe one crucial things to point out is that the platform is more for data analysis and making sense of the data or working with the data rather than doing row-level processing. So if you have some row-level data which needs a lot of processing, IHID might not be the platform for that. But once you process the data, linking it with clinical information, linking it with demographic information, linking it with other modalities is the perfect use case for the platform.
All right. In 1 minute, maybe Alex, if you want to take it, would you be able to explain the revenue sharing model for a for-profit organization?
Yeah. So, basically we have like a standard agreement as which, let's say we partner with a data provider, data registry, right? And I think a good example is with Dr. Andrew Cron, who's the PI on the HERO data registry. So we've actually partnered with him on the genomic data that they have, and we've established a revenue sharing agreement. So what does that exactly mean? So let's say a pharma company comes to us, wants access to that specific genomic data that they've collected. Depending on the requirements, how much data is required from HERO, how much data is required from PHC. that is kind of the revenue split based on the fee that's associated with that specific project, right? So let's say it's like a $100,000 project, and Hero is providing 75% of that data. We're providing 25% of that data. It's not exactly a one-to-one in terms of the fee sharing structure, but it'd be something along those lines, because again, it's most of the data is being provided by the Hero registry. So that's kind of an example of how the revenue sharing model works. And we can, if there's any data providers within the room, can have that discussion to see, what makes the most sense. And, those fees go directly to Hero. The fees go back into Ventures, which again, even though we're a for-profit organization, all of the fees that we receive go back into Providence Healthcare.
That's a very great presentation, and thank you for the audience for being so interactive with us with all the questions. I really loved hearing and all the details, how the platform has evolved. It's amazing, the free access, yay. Thank you so much for all of you for being here.